Greetings, I am Dr. Kim Kyung-won of Online Surgery. Let's look at the surgical clip and have a discussion. This is the patient, 69-year-old female patient at initial visit. This is the panoramic image. The patient's medical history. The patient is 69-year-old female patient and she has received injection for osteoporosis. She got injection 4 or 5 times, once in every 3 months. And the patient was to receive osteoporosis injection in March, but I asked the patient to skip it this time around. In March, she did not take the injection and surgery was executed at the end of June. The patient skipped 1 injection. More so than having oral medication, when the patient takes injection, it can be problematic. However, it has been approximately 1 year if you look at the patient history, and I believed that there will be no major issue. Number 34 is missing. We need to place implant here. If you look at the CT, there's a lot of alveolar bone destruction on buccal side. In this case, implant will be placed if there is dehiscence defect. I plan on using OssBuilder for GBR. For primary closure of soft tissue, periosteal releasing incision is necessary. In the case of lower premolar, mental nerve can be a problem. Number 34, so it's slightly mesial to mental foramen. In the lower premolar, if you do GBR, you need to be careful about managing flap on the buccal side to prevent damage to mental nerve. This is CT image. As shown, the buccal plate loss can be observed in the extraction site and it is quite resorbed. One guide is used for surgery. Implant studio is used for anticipation. Because it is premolar, 4.5 millimeter implant was planned. Dehiscence defect, if it is exposed, in order to maintain the volume, I'm going to use 3D preformed titanium mesh from Osstem, the OssBuilder, for GBR. In the case of lower premolar, the cortical bone can be hard. For bone formation, blood supply is necessary and perforation on cortical bone will be done. TS3 diameter 4.5 by 10 millimeter implant was planned. The bone itself is lower posterior area. I assumed it was normal bone. After initial drill, 3.5 one-guide drill is going to be done. After that, 4.5 one-guided drill will be used as final drill and implant will be placed. Implant will be placed and cortical bone will be perforated. In my case, after implant is placed, cortical bone perforation is conducted. After that, GBR is going to be done using OssBuilder. When I use OssBuilder for space maintenance, titanium is very good. However, the titanium mesh does not serve a role in GBR, and on the buccal side, to protect mucosa and to get better result, I use collagen membrane on top of it. This is the post-op image. The implant has been placed to the desired position. It has been placed deep. On top of it, OssBuilder has been placed. On CT, you can see that the implant has been placed in the planned position. In my case, where the implant is in contact with host bone, I use allogenic bone for bone graft, and on top of it, I use bovine bone graft for space maintenance. As mentioned earlier, this is close to mental nerve. I hope I had done ablation a little more and did more bone graft. However, when I was actually doing the surgery in order to protect the mental nerve, I did ablation slightly less and bone graft is not sufficient down here, and this could have been done better, but you can see that the surgery was done as planned. If you look at CT on the defect area, OssBuilder was used for sufficient bone augmentation on the buccal side. Let's look at the surgical clip. I'm going to adapt one guide template to see it fits well. As shown, I check once again whether it fits well in the area with the adjacent teeth. After implant placement, GBR is going to be done on decent defect, and I'm going to make incision to reflect flap first. And I'm going to reflect the flap and then adapt one guide template once again. For final drill, 4.5 by 10 mm one guide drill is going to be used. In order to reduce heat generation, I do a sort of pumping action. TS3BA 4.5 by 10 mm implant is placed as mentioned. This is a hydrophilic implant. Before placement, you need to irrigate it sufficiently. Then, even if saliva gets on or if there's contamination, the implant will not be covered by biofilm. Make sure that the template does not move. And I'm checking the final position of the implant. Primary stability is over 30 Newton centimeter. One guided template is removed. For GBR, incision is going to be extended. As shown, there is decent defect superior to the implant. In the case of lower premolar, when you elevate the soft tissue, you need to consider the position of mental nerve. Smart peg is connected. I'm going to check stability once again. I'm going to check ISQ value. It's approximately 82. Primary stability is good. Because buccal bone is hard, I'm going to perforate the cortical bone. In this case, I'm using lens drill. I'm checking the position of the implant and am perforating the cortical bone. Depending on your preferences, some people do perforation before implant placement, but I normally do it after implant placement. In the area where the implant is in contact with the host bone, I use allograft first. And then on top of it, I'm going to layer it with xenograft or bovine bone. Layer graft or sandwich graft is done. So you want new bone formation to be done nicely, inferiorly, and on top of it, in order to maintain the volume, OssBuilder is going to be used. In order to fix the OssBuilder, I'm using covered cap. In my case, I don't trim the buccal side of OssBuilder. The top side, at times if it hits the adjacent teeth, I trim it slightly using scissor. Because the flap is lacking, releasing incision is done. This is in front of mental foramen, so I try to release more mesially. You need to be careful of mental nerve in this case. If you believe this is very close to mental nerve, at times you need to expose and check. On top of OssBuilder, because OssBuilder does not serve a role for GBR, I'm going to use OssGuide, the collagen membrane. I have a big OssBuilder here, so I'm using 2 collagen membrane. Periosteal releasing incision is done so that the flap can be approximated without tension. It is lower premolar and lingual flap can tear easily. I am using adjacent teeth as an anchor for suturing. I'm going to do mesial side first to get the position of the flap. And then I'm going to suture the distal side. Interrupted suture is done. As shown, OssBuilder is used to do GBR on dehiscence defect, and on top of it, OssGuide collagen membrane is used. After that, suture is done. Implant placement at the same time as GBR using OssBuilder was done. Personally, in this case, I like to do a layer graft using allograft and xenograft. Thank you for watching.